everyone. For the next few minutes, I would like to introduce you the topic of my project, optimization of acute pancreatitis management. But first, let me introduce myself. My name is Cristina Patoni. I am a gastroenterology resident in the military hospital in Bucharest. Last year, I studied my PhD at Harvard University, and this year I am part of the translational medicine program, sponsored by the MOL group, and by this way, I would like to thank them for giving me this opportunity. My supervisors are Dr. Valenteros and Dr. Heikki Peter Jr. My scientific methodology supervisor is Stefania Munduk, and statistician is Daniel Beresh. My vision regarding acute pancreatitis is that we can decrease the complications and mortality rates by improving the management, and the mission I will have is to fill the gaps that are in the guidelines in order to prevent the development of the severe acute pancreatitis, which has major implications and consequences. I started two projects. Both of them focus on the treatment of acute pancreatitis, as this is a serious disease that is increasing worldwide, and in contrast with the incidence, there is little trend on the mortality, which remains high. 50 to 20% of the cases with severe acute pancreatitis patients die because there is a lack of specific treatment, especially in the organ dysfunction. And now let me introduce you my first project entitled Efficacy and Safety of Prophylactic Anticoagulant Treatment in Acute Pancreatitis. The basis of this concept is the fact that acute pancreatitis is an inflammatory disease, and as a consequence, it is associated with vascular injury, activation of coagulation, and increased leukocyte rolling. Hypercoagulability observed in inflammation is a result of the inhibition of natural anticoagulants and an inhibition in the fibrinolytic activity. There are several studies in the literature that show that the use of anticoagulants in acute pancreatitis is able to reduce the severity and accelerate the recovery of these patients, because in addition to their well-known anticoagulant effects, they have the ability to regulate the inflammation by reducing the liberation of cytokines and other inflammatory mediators. Unfortunately, there is no data about prophylactic anticoagulant treatment in our guidelines. So our aim is to assess the safety and the efficacy of anticoagulation treatment of acute pancreatitis and whether it may improve its prognosis. Our clinical question would be, is administration of prophylactic anticoagulants safe and does it improve prognosis in acute pancreatitis? And for this we use the PICO framework. And the hypothesis is that administration of prophylactic anticoagulants is safe and improves the prognosis. And the clinical indication of this is that anticoagulants reduce the severity and prevent the thromboembolic events, which range from 2 to 36% of the cases of acute pancreatitis, and have major and little complications, such as development of gastrointestinal bleeding, ischemia, bowel ischemia, and complications related to the development of portal hypertension. We conducted our search key on three main databases on October 2021, and the search key contains two concepts. The first one related to the anticoagulants, and we included all types of anticoagulants, and the second one is pancreatitis. With this search key, we were able to identify 8,552 studies, and after all the steps, we have, after the full text selection, we have 11 eligible articles. And now let's move forward to my second project, the safety of early versus late endoscopic or percutaneous interventions in infected necrotizing pancreatitis. Acute pancreatitis develops, necrotizing pancreatitis develops in 5 to 10% of the cases of acute pancreatitis. And infected necrosis occurs in 40 to 17% of these cases. Regarding the timing of the drainage, there is a debate in the literature. So on one hand, we have the European guidelines that assess that the first intervention should be delayed after 4 weeks. And on the other hand, we have the American guidelines that recommend the percutaneous drainage to be done in the early phase, less than 2 weeks. So, our aim is to evaluate the safety of early versus late interventions in necrotizing pancreatitis. And we will use the PICO framework for this one as well. The clinical question is, are early endoscopic percutaneous interventions safer than delayed interventions in infected necrotizing pancreatitis? The hypothesis is that postponed interventions are safer than early intervention in the infected necrotizing pancreatitis, and the clinical implication for this is the fact that we will be able to set the perfect timing for the drainage. We conducted the search on 5 databases. This is a preliminary search. And the search key has 3 main concepts. The first one is pancreatitis, the second one related to the collections, and the third one is related to the intervention. So, as an overview, we aim to submit the first project by March 2022 and the second project in June 2022. I would like to thank you for your attention and to not forget that great things are done by a series of small things brought together. Thank you. If there are any questions.
According to the classification or version of the Atlanta classification, it's evidently the progress of acute pancreatitis is very nicely, timely followed. So it's hard to mix together the percutaneous intervention, which is made in the first 2 weeks in the clinical practice, and the endoscopic intervention is mainly performed after 4 weeks with the strong wall of the wall of necrosis or pseudocysts. So that's quite different techniques.
They are different techniques, but we relate only on the timing of. We divided the pool in less than 4 weeks and more than 4 weeks. Even they perform the endoscopic procedure even earlier than 4 weeks in some studies. So we will include them in the early pool.
Congratulations. Based on your hypothesis, why do you think that the later procedure is safer in infected case?
I know. This will be my first impulse was to think that early intervention in the infection will be a better one. But after reading the literature studies, I realized that delayed one is the best option. It decreases mortality and all other outcomes like new onset organ failure in every study that I read.